Just waiting for the stream to start. Sorry, just bear with me one moment. Oh, sorry, we're live now, Councillor Hudson.
Thank you, Richard. Well, good afternoon, everybody. And I would like to begin by welcoming those members of the public and the press who are watching the live stream of this meeting via the Council's website. Members, you are by now very much aware of the need to keep your video camera switched on for the duration of the meeting, unless, of course, there are technical issues, and to keep your microphone muted, except when I invite you to speak. Please remember to use the raised hand function if you wish to answer a question or make a comment. There is, of course, always a risk that we may run into technical problems, and I would ask for your patience if we do. Should this occur, I will declare an adjournment while the fault is addressed, and the public broadcast will be paused. If it is not possible to address the fault, the meeting may be abandoned until such time as it can be reconvened. Can I remind members and officers and any speakers that all virtual meetings will be recorded, and these recordings will be published on the County Council's website. Can I now go, please, to attendance? So, members, I will begin by calling the names of all members of the committee to establish your presence. Could you please unmute your microphone when I call your name and confirm your presence by just saying presence? Thank you. Councillor David Connor.
Present.
Councillor Lorna Dupre.
Present.
Thank you. Councillor Mark Goldsack.
Present.
Thank you, Mark. You're subbing for Councillor Kevin Reynolds. Councillor Anne Hay.
Present.
Councillor Linda Harford.
Present.
Councillor Mark Howell.
Present.
Thank you, Mark. You're subbing for Councillor Mandy Smith. Councillor Linda Jones.
Present.
Councillor Lucy Nessinger.
Present.
Councillor Susan van der Ven. Susan? Have we lost Susan? Vishenda?
Present.
Oh, thank you. Oh, there you are. East Cambridgeshire District Councillor David Ambrose Smith.
Present.
Fenland District Councillor Samantha Clark.
Present.
South Cambridgeshire District Councillor Jeff Harvey.
Present.
Cambridge City Councillor Nikki Massey.
Present.
Huntingdonshire District Councillor Jill Taverner. Shenda, is Jill not there? Okay.
Not yet, Councillor Hudson.
Okay, fine. We'll move on. And myself, Councillor Peter Hudson. I'd like the committee to note that at the May annual council meeting, myself and Councillor Hay were appointed as chair and vice chair respectively. Item 2, apologies for absence and declarations of interest. Can I please welcome our new officer, Rob Sanderson, and also for the minutes, please, Rob, I'd like to thank Dan Snowden, our past clerk, for all his years of dedication and support to this committee. So, Rob, you're very welcome. And can we have apologies, please?
Yes, many thanks. Yes, Councillor Smith is a apology. Substitute is Councillor Howell, Councillor Reynolds is a substitute, and the substitute is Councillor Goldsack.
Thank you. Members, does any member wish to declare any disclosable pecuniary interest or non-statutory disclosable interest? If you do, could you use the raised hand, please? Susan, you raise your hand. Would you like to unmute yourself and declare your interest?
Sorry, I can't get the big screen. I declared this I just declared this last time, and I probably need just to have it on my record that my son works at Addenbrooke's, and I feel I should declare that. Thanks.
Yes, thank you for that. Item 3, the minutes of the previous meeting held on the 5th of May. We are being asked to approve the minutes of the meeting of the 5th of May 2020 as a correct record. Can I ask, please, any member who does not agree with this proposal to click the raised hand function on the right of your screen now, or if you're Councillor van der Van, just wave at me. And there are no raised hands, so we'll take the minutes as read, and I will sign them as soon as we're lucky and able to get back to Shire Hall. Thank you. Item 4 is the action log. An updated action log has been included in the published papers for this meeting. All the actions are in fact marked complete. If any members have questions on the action log, will they please use the raised hand function on the right of their screen to show this? Councillor Jones. You have a raised hand, Linda. Want to
Yes,
unmute yourself?
Yes, indeed, yes. I wanted to comment on the variability of the responses. It was a tremendous achievement to get all those responses together. But in relation to particularly the responses on care homes, in Appendix 1, it seemed to me that some of the answers were very brief. And some of them indeed didn't really go as far as the information we have in the local press, for example, or from local hospitals themselves. You know, for example, we have now a statement from Addenbrooke's that 112 patients were discharged in the early days without COVID testing. So I'm a little bit disappointed about the quality of the answers on care homes. And I would like to encourage as much disclosure as possible.
Thank you. Liz, could I ask you to come back on that, please, as Director of Public Health?
Yes, when the responses were made across adult social care and public health, information that was held was provided. I don't think we would have had the information that Addenbrooke's has now published. Certainly we didn't hold it in public health, and I don't think adult social care would hold that. So inevitably different organisations hold different information, and they may provide that at different times. But there is always a balance, clearly, because care homes come to the council for support as their commissioners, and they need to be able to do that with confidence and understanding that where it's appropriate for them to share information with us confidentially in order for us to help and support them, then they can rely on that. So there is always a balance in terms of operational commissioning of services between appropriate confidentiality in relation to the organisations concerned and the publication of information. But I can assure you that a great deal of hard work went into those responses, and a lot of work was done to inform members and the public of the situation. And in addition to the answers to the questions, there is also a question and answer, a Q&A on care homes, which I believe is also in the papers. So I hope that's helpful, Councillor Jones, even if it doesn't entirely satisfy your question.
Thank you, Liz. Councillor Jones, do you want to come back on that quickly? Or are you happy with that response?
Well, there are a lot of issues. It's difficult to know when to pick them up. I mean, this is an historic report. I have got questions I'd like to ask about how things are being handled, but I think they come up better in the paper that we're going to have later on.
Yes, agreed. Thank you. Councillor Harford, you'd like to make a comment?
Sorry about that. I'm just wondering, in view of what Councillor Jones just said about it, may be better to bring up some of the queries about things that are resulting from the answers to the frequently asked questions later on. I can do that then. Shall I leave it until then, or shall I ask questions that relate to some of those answers now?
Let's leave it till we get to the relevant paper, Councillor Harford. That might be more in context. Thank you very much. There are no more raised hands, so I shall now take the action log as noted as requested. Thank you. Item 5, petitions and public questions. We have received no public questions or petitions, so I'll move straight to the next item of business, item 6, which is co-opted district councillors appointments. Ask Rob Sanderson, please, to update us with the district council appointments. Rob?
Yes, Huntingdonshire District Council have reappointed councillors Mrs Jill Taverner with councillor Mrs Sarah Wilson as her substitute. East Cambridgeshire Council have reappointed councillor David Ambrose Smith with councillor Julia Huffer as his substitute. Cambridge City have reappointed councillor Nikki Macy with councillor Anthony Martinelli as the substitute. South Cambridgeshire District Council have not had an annual council meeting, so councillor Jeff Harvey remains their member and councillor Alex Mallion the substitute. Finland District Council have reappointed councillor Sam Clark.
Thank you, Rob. And as always, a big welcome to our colleagues from the district councils. Your contribution to this committee is very much appreciated, as it is vital. Can we go on now to item 7, please, Mr. COVID-19 issues report by the Director of Public Health. This report was circulated to members yesterday on email and also via the link from the CMIS automated email. Officers have been asked to bring a report on the COVID-19 response to date for those services for which each policy and service committee is responsible. Given the rapidly changing situation and the need to provide the committee and the public with the most up-to-date information possible and as available, I have accepted this as a late report on the following grounds. The reason for lateness is to allow the report to contain the most up-to-date information as possible. And the reason for urgency is to enable this committee to be briefed on the current situation in relation to the council's response to COVID-19 for those services for which it is responsible. Now, could I ask the Director of Public Health, Dr. Liz Robin, please, to introduce the report, please?
Okay, thank you, Councillor Hudson. So just to bring you absolutely up to date, I'll provide some information from our COVID-19 surveillance cell, which now meets daily, on the latest situation in Cambridgeshire. So it's on the whole, it is positive. There were 2 new what are called Pillar 1 lab confirmed COVID-19 cases detected in Cambridgeshire in the latest reporting period of 15th to 21st of June, making a total of 1,243 for Cambridgeshire. Now, the Pillar 1 testing is mainly for patients and staff in hospitals and for care home residents and is done in local labs. So it doesn't include those national testing procedures from the drive-through testing and internet testing and things like that, but it picks up those people who are most ill from COVID-19. So 2 new cases in the last reporting week is positive and shows that the levels of these types of cases are falling and low. Overall, our Cambridgeshire rate of Pillar 1 COVID-19 cases per 100,000 population since the start of the pandemic is significantly lower than the national rate. And this is also true for all districts apart from Huntingdonshire, which is similar to the national rate. So good news in terms of falling Pillar 1 cases. We've had 1 suspected care home outbreak in the last reporting period for that, 8th to 15th of June. And again, that is positive in that it is a relatively small number compared to what was happening earlier on. And in the latest Office of National Statistics recording week 24, ending Friday the 12th of June, there were sadly 4 COVID-19 related deaths across Cambridgeshire, but again, falling numbers. We have had a report from Office of National Statistics on our age standardised all-cause death rates and deaths related to COVID-19 for the March to May period, so beginning of March to end of May. And in Cambridgeshire, our death rates are significantly lower than the national average. We look at COVID-19 related deaths that are coded on the death certificate because clearly those are very much related, but we also look at deaths from all causes because we know that not all deaths from COVID-19 were necessarily coded as such. So we look at both of those, but we are better than the national average for that, although every death is obviously a tragedy and a loss to the people concerned. And the trend in both all-cause deaths and COVID-19 deaths since the initial peak is down overall in Cambridgeshire and all the Cambridgeshire districts. So we are following the national picture in terms of all the indicators of the pandemic trending downwards at this point in time. So I thought it was useful just to give you that overview. Moving on to the paper, I will focus on the Public Health Services response. It's actually headed section 4, but should be headed section 5, all the paragraphs, so 5.1, 5.2 and so on. So we're in a bit of a transition as a directorate at the moment. We have devoted a lot of our energies over the past 2-3 months to the all system COVID-19 response, supporting the multi-agency local resilience forum on a whole range of response issues, providing specialist public health advice from many staff in the directorate. And that includes a number of actions which you're aware of, such as jointly chairing the PPE Hub, Local Resilience Forum PPE Hub with the CCG, distributing PPE from the national stock to a wide range of health and social care organisations, working on mental health, working on a range of communications, including video blogs, work that Val's done to support vulnerable populations with the impact of COVID-19, running a stock take in a very structured way on that, close working with adult social care, and strong public health input to recovery work as well for the wider public health issues and impacts during the recovery phase. And clearly we need to ensure that our reopening measures which are happening now are as safe as possible and in line with national guidance. So at the beginning of June, something that was quite important was a publication by Public Health England of a review of disparities in risks and outcomes from COVID-19. It identified risk factors for poor outcomes, such as age, which was the strongest risk factor, gender, ethnicity, occupation, long-term conditions and deprivation. We've prepared a summary of this review and distributed it widely to officers across the system. Since late May, all of this work has continued to go on, but the main priority for ourselves as a specialist team has been to work to support the National Test and Trace programme, which was launched on the 28th of May, and in particular to support that through the development of the Cambridgeshire and Peterborough Local Outbreak Control Plan. And this is a national requirement to prepare a local plan to manage more complex outbreaks in Cambridgeshire and Peterborough, because we're preparing the plan jointly across the two, working closely with the Public Health England Health Protection Team, which is a regional team, and with our environmental health colleagues and other NHS colleagues and various others in the system. So we have, this is, as I say, a national requirement which places much more responsibility on local authorities and local authority directors of public health to provide a local response to manage local outbreaks, ensure that good contact tracing is done, and contain COVID-19 as we go forward. There are a number of requirements for these plans, which are outlined in the text. There are 7 key areas, key themes, which we are required to deliver against. And we are submitting our plan on the 30th of June to national government, and a great deal of work from the whole team and multi-agency work has gone into preparing this. We're doing this work through our local health protection board, which has been set up to bring the relevant agencies together. Again, that is part of the national directions. And that plan will be taken to the joint meeting of the Cambridgeshire and Peterborough Health and Wellbeing Boards, the Joint Whole System Subcommittee on the 29th of June, so that that plan can be looked at in public and everyone will have a chance to comment on it. To support the new ways of working required, we already have a surveillance group meeting daily to look at our local epidemiology of COVID-19 and local trends. And we've also set up an incident management centre to which any potential local outbreaks can be reported and which can then distribute information on as a single point of contact. And we're manning that appropriately. And thanks to Kate, who's also at the committee today, for her work on that. Finally, terms of reference have been prepared for a member-led local outbreak engagement board, which will be based around the membership of the Cambridgeshire and Peterborough Health and Wellbeing Board's core joint subcommittee, which is a small subcommittee of the 2 health and wellbeing boards, with both the leader of Peterborough City Council and the deputy leader of Cambridgeshire County Council as the 2 Health and Wellbeing Board chairs. We will also be co-opting the Health Committee chair, the Public Health Portfolio holder in Peterborough, and a district council member. And local members will be co-opted if there's an outbreak in this area. The purpose of this engagement board is to engage. It's not a decision-making board, but it is there to meet in public, which the Health Protection Board, which is an officer board, doesn't, and to make sure there's strong communication and political leadership around our local outbreak management plans. So I've spoken at some length there, but very happy now to take questions.
Thank you, Liz. I'd just like to say how much we appreciate you being here. I know you've been off poorly and you've taken a couple of days leave to recharge your very decreased batteries, but we're very, very, very happy that you've decided to join us today. And I'd also like to take this opportunity to thank the absolutely magnificent way our Public Health Directorate and all our staff have worked since this pandemic has hit us, and the many hours ably led by, of course, the Director of Public Health herself, who's personally worked many, many days and many, many hours, and still is. So if you could pass that on, please, Liz, I'll be very grateful. Okay, yes, I've got some, oh gosh, raised hands everywhere. Okay, so thank you. Use your raised hand function to indicate you want to speak. Thank you. And could I ask, please, that you keep your questions relevant to the report and relevant to this committee, and not ask questions that are within another committee's remit, giving our staff extra work. As members, we can all go to other committees, chairs, vice chairs, members, and officers of those committees to get the information we require. So this is a health committee questions, please. And I'll start off with, the first one was Councillor Van der Ven. You're on mute, Susan.
Yeah, sorry, I was waiting. I think Linda was ahead of me. But...
No, your hand come up first.
Okay. Thank you very much. And I'd like to echo the chairman's thanks to Liz and the team. We know you've been working flat out. I wanted to ask if you could shed some more light, please, Liz, on the reason why Huntingdon statistics are consistently poorer. That was one general question. And then in the Public Health England report that you referenced a minute ago, were there any particular criteria or risk factors that are associated, that are unique to Cambridgeshire, just extrapolating out of that general picture?
Thank
Okay.
you.
Thank you, Susan. So for Huntingdonshire, we have worked with Public Health England epidemiology unit to try to understand the higher rates of infection in the Huntingdonshire area, although even there the rates are not above the national average, although higher than some other parts of Cambridgeshire. And what we have found when they looked at the source of the cases was quite a strong association, which you see in many areas, with health and social care settings. So it wasn't a picture of very widespread community outbreaks. It was more a picture of some quite high infection rates around health and social care settings, which, as I see, has been a pattern, particularly for the later stages of the pandemic around the country. It started as a general community peak, which in Huntingdonshire was actually quite low, but then peaked later and showed quite a lot of cases around the health and social care setting element, if that's helpful. And that's the feedback that we've had from our epidemiology colleagues. So the Public Health England report, I would not say that there's anything unique to Cambridgeshire, but it does point to risk factors that are relevant for different parts of Cambridgeshire. So in some of our rural areas, the very strong association between age and vulnerability to poor outcomes is important, because some of our rural areas have large elderly populations. In Cambridge City, you would be looking more at the risk associated with higher urban density, and also potentially with risks associated with ethnicity, because Cambridge City has quite a mixed population in terms of Black and minority ethnic groups. There's also an association with deprivation, and I think there we might be looking at some small areas in Cambridge, but particularly to parts of Fenland, where there is deprivation and concerns about issues associated with deprivation, such as poor housing, where it's hard to socially distance, and therefore you're more likely to get spread of infection. So a great deal of learning from the report, and that's why we've distributed our summary quite widely, because each organisation and each setting in a sense can take out those issues which are relevant for them.
Thank you. Thank you, Liz. Susan, are you happy with that? Do you want to come back quickly? No, thank you. Now we go to Councillor Linda Jones, please.
Thank you, Chair. Can I just extend thanks from me to the public health team, because one of the things I've been doing across the epidemic is to summarise, try and pull together all those reports that have been coming out weekly from across the whole council. And one of the things that's very noticeable when you do that is that public health pops up everywhere, because in terms of doing all the coordination work, in a way, the mortar among the bricks and the coordination, public health is really very central. And so I realised that behind that, there lies a huge amount of work. I wanted to, in fact, I'm going to do I had 4 issues I wanted to raise, but I'm going to pick up the one that Susan started with, because I think that's important. It seems to me that at some point, and I know now is not the time, at some point, the very interesting data that's on page 3, which looks at directly aged standardized rates of mortality and signals the issues in Fenland in terms of how high that is. And some of the other issues about the variation in COVID itself, but also in mortality rates, seems to me that it's fine to extrapolate from that what the risk factors are, but we also need to kind of move on and say, as a health committee, knowing what we do about areas of concern, of deprivation, indeed of investment, as in Finland, can we then look at the bigger health inequalities picture? What is the correlation or even the relationship between the way that COVID-19 has struck and the way that our health inequalities are embedded across our population? And I'm not sort of expecting an answer now, but it seems to me from a public health point of view, in the future, it's a really important question to ask ourselves as a health committee. I had three sort of smaller issues, one of which, according to the chair's strictures, might be ruled out of order. But I noticed in paragraph 5.5, the stock taking work, and I'd seen that coming up. I know it's been gradually happening over the last few weeks. And I wanted to ask a question related to that, which I know that is very close to our Director of Public Health's heart, and that is about homeless people who, of course, have been moved into hotel accommodation. And I wanted to, I know that in some councils, they've been moving them out of the hotel accommodation as the funding for that has ended, back onto the streets, and there are obviously considerable public health issues. So even if our Director of Public Health can't answer it, it will be good to take that issue forward and find out where it is being done across Cambridgeshire, what can be done for homeless people who may be back on the streets. And obviously, to some extent, it's about work with the districts. So that was my second issue. I don't know if you want me to stop and
Can we stop there? Linda, let's just stop there. I mean, I
Yeah.
know for a fact that Fenland District Council are moving homeless people from hotels into accommodation, which is good. I will let Liz come back if she has some sort of answer for you, but this is the sort of thing we need to take forward and discuss at the next chair, vice chair, lead members, and how we can involve our colleagues from the districts on this. Liz, do you want to come back?
That's helpful.
Briefly, please, Liz. Yeah.
Okay, that's fine. Firstly, I'd like to thank Linda for her support and thanks, and say that I have got a fantastic team who have been out there with all the council directorates and partners putting in public health support. So thank you, Linda. And we will come back to you on the health inequalities issues, which I think will become more apparent as time goes on. On the stock take work and the homelessness, I'd actually like to refer to Val Thomas, who has been very closely involved with this and who I believe is on the call, and she may be able to update on her work.
Val's waving at me at the moment. Val, do you want to come in, please?
Yes. Yes, so from the start of COVID, I've been working with various organisations that work what we call socially excluded groups, and the homelessness population has been one of our main concerns. And I think everybody who's worked on this initiative has really appreciated how, and the feedback from rough sleepers that have been housed during the period, the advantages in terms of the access to services, in terms of the support they've had, and I think that's throughout the districts. It is certainly very, very much on the agenda of the housing board. I now go to the sub-regional housing board every couple of weeks, and each of the districts report back on how they are trying to make this move and to take the learning. Obviously, they are waiting for more indication from the centre around funding. But alongside that, there's a lot of work being done by the CCG, for example, in terms of ensuring that as they're developing their services, that they are more responsive to the needs of the homeless. So we have examples in Cambridge City where we have the access practice, but what we've learned in the course of COVID is that for rough sleepers is that we've certainly improved their access to many services. For example, there's been a huge increase in registrations at the practices in Wisbech from the homeless populations. So I think that there's great progress that's been made in many ways, but I think the challenge now, which all the districts are really working very hard to address, how can that be translated into action going forwards? And I'd be happy to, and I think it would be good to engage with districts in that conversation, as I think you mentioned, Councillor Hudson, as I think it's extremely, let's say, it's at the front of their concerns at the moment.
Thank you, Val. Go back to Linda. Do you want to continue? You've got another question, I think.
Thank you. That's very helpful. And I think that's a very helpful way forward. It's obviously not something you can kind of deal with in committee, as it were, but the issue important to raise. I had two other points, Chair, if that's possible to raise those, and they both relate to the test and trace issue, paragraphs 9, 10, 11. The first one, I think, is about what happens in densely populated areas, because my understanding is that what when government is asking local authorities or local areas to act, they're giving them postcode information about where the outbreak is, but they're not giving specific information about addresses. Now, this is fine if it's in a rural area where, or a relatively sparsely area where you can identify the care home or the whatever it is where the outbreak is. But I think it could be an issue in a densely populated city area, in Peterborough or in Cambridge, or maybe in Ely as well, or St Neots, where you've got potential sites for the outbreak quite close together. I may be wrong about this, but this came up on a national webinar yesterday, that the only information that was being given was postcode and not about addresses. And that sort of worried me, because one of the messages through this is about how the coordination between central government and local government is actually happening and how much coordination there is. So that was the first one. And the second one was to understand the testing issue in relation to care homes. And closed environments in general, because we know that people may be tested and they may not have symptoms, and then a few days later they will. So in a way, I guess what's needed is a program of continuous testing. And I didn't see anything about that in the paper. And I wondered what the frequency of testing was. And you know, that may be an issue that is simply a detailed issue.
Thank you.
But I good to get an answer.
Okay, thank you, Linda. So in terms of the postcode information, the issue of information sharing between the Test and Trace programme and Public Health England and local authorities is a very live and active one. Because everybody understands that in order to effectively manage local outbreaks and trace contacts together, we need to share information. I think certainly locally, if there is an outbreak in a setting, that help is needed with, then we will have direct contact with our regional Public Health England Health Protection Unit, which does have access to the Test and Trace detailed information, and they will tell us the name of the setting, if you know, so that these things are reported to us. They are reported to us confidentially under official sensitive headings, but for operational management of an outbreak, we are told where the setting is, so we're not left guessing and trying to find it. I think the issue that is more challenging and that requires some further work is around individual contacts and how to contact them and sharing personally sensitive data. At the moment, Public Health England Health Protection Team would do the follow-up with contact tracing and have those individual details, and at the level that outbreaks are at the moment in the community, that works because they have the capacity to do it. If we had a surge in outbreaks and we needed to do more of that locally, we need all of those arrangements set up in advance so that personally sensitive individual information can be shared with us where necessary in order to trace contacts and act on that. So that's a very active discussion, and lots of people working on it. But at the moment, we're not left in the dark with just a postcode. We are communicated with if you know, about any local outbreak, and are then able to mobilise our local resources such as environmental health officers or infection control nurses to support. On the testing issue, as you know, there was an offer from government that all care homes with elderly residents or residents with dementia should have a complete care home screen of staff and residents, should be offered that by the 6th of June. So that was a very specific programme. I think that there is still debate about whether all care homes should be routinely screened, and that is going on at national level as well. From what I've seen, there have been, and this is just informal really, discussions amongst professionals. There have been proposals, yes, could we do that? And then this is the testing capacity that it would use. And actually that's a great deal of testing capacity, and is that needed as the frequency of outbreaks in care homes decreases. So I think that question is still open. That work has been done, and certainly what happens is that if there is any suspicion of a resident with symptoms in a care home, that is immediately should immediately be reported as an outbreak, even if there's no positive COVID-19 test. So outbreaks are reported to Public Health England just on one symptomatic resident, and then there will be very active testing of that care home, people who are asymptomatic as well. If there is a positive test. So there's work going on, but I don't think that as far as I'm aware, the case for very frequent screening of all care homes has not fully been decided yet.
Thank you. Thank you for your questions, Linda, as always, very pertinent. Are you happy with those? Do you want to come back briefly?
No. I mean, I think other people want to ask questions as well, so I'm happy with those.
Yeah, you're very kind. Thank you very much. Councillor du Preez, please.
Thank you very much indeed, Chair. Just one question. The report talks about outbreaks in particular premises, and it mentions schools and care homes and so on. One form of premise that isn't mentioned, but which is very prominent in the news day by day, type where there seems to be a high number of outbreaks, is food factories. We've seen outbreaks in food factories in Gütersloh, 3 in Wales, and now Prince's in Wisbech. Because of the nature of our area, there are obviously quite a number of food premises in Fenland and East Cambridgeshire in particular, given the nature of the local economy. And I wondered how the public health team was working or was planning with food factories, food packaging industry and so on to reduce risk and to address the potential for outbreaks in those situations.
Thank you, Lorna. There was a briefing paper about this outbreak, was emailed us all yesterday.
Just unmuted, yes. Oh, sorry, I just unmuted. Yes, we've been working very much with environmental health officers that in the districts who historically and now have a responsibility for any type of outbreak in workplaces. And they've been for a long time sending communications about measures that they should do to the outbreak that they had. And on the back of that, that was followed up by the EHOs at Fenland District Council, giving them an additional support and I think that's a model which I think they are seeking to replicate with our support. So it's been very much a joint effort. And alongside that, for instance, if you have a lot of the employees who perhaps live in houses of multiple occupation, which Liz referred to earlier, we also followed up with the HMOs as well, that are occupied by that particular workforce, to give them to reinforce the information that we'd already given them. And this is embedded into our outbreak plan, which was referred to earlier. And I think we will develop this work. And I think EHOs will have a very big role to play in outbreaks as in workplaces as we go on. Hopefully there won't be too many, but I think they have a very key role, and part of that is giving that prevention information.
Okay, thank you very much.
You're muted, Peter, when you were talking.
Thank you, Mark. I'm asking you to speak, Mark. Thank you.
Okay, thank you, Chairman. It really follows on from Councillor du Preez's question, which was a question I was going to ask, so thank you for that. It's reported that yesterday a school just over the Suffolk border in Exning had a confirmed case of COVID-19 and therefore went into their bubble protocol of closing down that particular bubble and sending everybody home, including the teaching staff involved in that bubble. I was just wondering whether A, we've seen anything since we've restarted the schools in bubbles in Cambridgeshire, and B, looking for some confirmation that we've got those procedures in place and how we act. Now, that may be more John Lewis than this committee, but I think it's relevant to where we're at. And the second kind of live news was I wondered if there's any actual factual news as opposed to some of the stuff that we're getting recently around the current situation on a vaccine that's going to be out within 6 months for 40 million people, which was some headlines that I read yesterday.
Thank you, Councillor Goldsack. Liz, this may be more education than us, but do you have a short answer for Councillor Goldsack, or should we refer him to the Education Department?
No, we're fine. We have set up what we call a schools cell, where we work across public health and the Director of Education to support schools. And we have agreed protocols and standard operating procedures, well, an agreed memorandum of understanding as to who does what. If there is a case in a school across Public Health England Health Protection Team and our local area. So the procedures are actually very well laid out and will be included in our local outbreak plan, but are currently functioning well. And Raj, who's at the meeting, sits on that school cell as our lead for children.
And I can confirm that we have acted on some confirmed cases in exactly the same way with the bubble going home. We also collect information on suspected, so children who are staying at home. So we have a school, schools inform us whenever they've sent children home, even when they're suspected, and then we get their test results back, and the schools tell us when their test results are back, and we get the information from the health protection team as well. So we can triangulate that data. And we have had this instance and exactly the same thing has happened.
Thank you, Raj.
And on the vaccine, I don't have the complete inside track on this. I know that there are some very promising developments, but vaccines do take time to test, particularly when the amount of COVID-19 in the community is lower, because you have to give someone the vaccine, then you have to give them the opportunity to be exposed to COVID-19 and not to catch it, which may take some time, given that in the community, we think about 1 in 1,700 people have COVID at the moment. So my understanding of the vaccine situation is that we've got some very clever people developing vaccines, but my assumption would be that they need some more testing before we know exactly where we are, if that's helpful.
Yeah, thank you. Thank you. Thank you. Councillor Netzinger, please.
Thank you. Thank you. I'd just like to echo the things that other people have said about the huge thanks to the public health team who have worked incredibly hard at the moment. And I'm also very glad to hear that Liz has taken a couple of days off. Yeah. I should think, given the amount that you've all been working, I should think the whole team need to make sure that they get a few days off when they can, because it is absolutely exhausting. So to come, my questions are partly looking back at where we were and then very much looking forward. So I think we're all aware that most of the cases in the recent past have been within care settings and within some settings, and that was a particularly awful phase of the pandemic for this country. I think that it's likely, given the relaxing of lockdown, that we're going to be moving out of that phase as more and more people are sort of circulating back into normal life and the virus is still around. So my questions really are, I think we've got quite a good idea about how the test and trace system is going to work through the County Council and through Liz's team in terms of tracing people in settings. But I'm not at all clear how that's going to work when you end up with outbreaks that are not related to particular places. So we've been talking about care homes and schools and meat packing plants. Those are all places where you have a limited number of people coming and going, and tracking contacts is easier. When Jesus Green swimming pool reopens again in about 10 days time, maybe slightly less, there's going to be a huge risk of very large numbers of people coming in and out of that. It's just an example. I don't know whether Jesus Green is, but I mean, there will be places where there are large numbers of people circulating around. who are much less easy to trace, and we don't have a contact tracing app at the moment. How are we going to manage if there is an outbreak that is not based in a setting? Do we have any capacity for shutting down an area smaller than a district? Is there any mechanism for us to do that at all? And if not, do we have any idea about how we're going to control outbreaks so it doesn't get out of control again?
Thank you, Liz.
I think that is a large question.
Very,
Metzinger. What I would say is that when we're not looking at specific settings, the contact tracing is done through the National Test and Trace system. So people get their test, they're contacted, they provide information about their contacts, and clearly if they'd been in a crowded environment, such as, you just used an example of a swimming pool, but if they'd been in a crowded environment, then they may be able to report some contacts there. That is very much why in the national system you have skilled health professionals interviewing the cases and ensuring that appropriate information about close contacts is picked up. So I think it is an interesting question. What I would say about local powers is that at the moment, we don't think that we are going to be given local powers to shut down a street or shut down something else. There are existing powers through environmental health and to some extent through the Coronavirus Act, but that can be used to shut down particular shops or restaurants or settings where there's a need to shut the setting down for public health reasons. So, for example, a swimming pool could probably be shut down through a Section 2A order worked on by Environmental Health, Public Health and a magistrate. So there are a number of ways through public health legislation that you could do specific things. Having said that, we feel that the community, residents now have quite a lot of understanding of COVID-19. And in reality, in a situation like that with a major local issue, you would want to be communicating directly with your population, advising them to practice social distancing, advising them to stay at home, advising them to try to reduce the spread of infection in ways that they understand. So I think there's a very, in the sort of situation you described, there's a very big communication and engagement element with the local population. And then there's potentially an enforcement element as well, if that's helpful.
Yeah.
Can I just?
Yeah, quickly, please, yeah.
It's possibly helpful, but also quite worrying. I think if what you're talking about is that there is not really going to be the capacity to shut down a local area, and it's going to have to be done via communication with the public to try and ask people that to explain that an area is at risk and people should behave differently. It's critically important that we get really fast information and that information gets out to the public very, very quickly. So can I just ask one final question about this, the speed at which you are getting information back from that national data, from that test and trace system about whether, so would you, how many hours would it take between there being a potential of an outbreak, say of 10 or 15 cases in a street, and you being able to get that information out to the local press?
That information would come firstly to Public Health England Health Protection Team as tier 1 of the response, and then would be shared with us. I can't give you an exact answer to that at the moment, Councillor Metzinger, because we haven't experienced that situation. But the information flows, I've been watching them improve on a daily basis. So there's a lot of work going on to do that. And I would of course also say that while I'm not aware of any local powers that we will necessarily have, there remain national powers. So in a very difficult situation, there are very wide-ranging powers nationally, which I suppose potentially could be used in a local situation if necessary, if it came to that. So it's not that there's nothing at all. But I agree with you, the speed of information flow is very important. As I say, I'm aware of a lot of work going on that, and that it's very, very significantly improved even over the last 2 weeks. So that's,
thank you.
Thank you. Thank you, Liz. I've got 3 more speakers on this, and then we're going to move on, please. Councillor Hay.
Thank you. You mentioned earlier the 7 key themes of the local outbreak control plans, one of which was assessing and developing the capacity and capability to scale up contact tracing for local outbreaks. Has this worked well? Particularly, I'm thinking within the case of the Princess Factory, which I believe there were 14 identified cases. And what I would also like to know is, since contact tracing has been introduced, was the Princess Factory the one that has the most identified cases, or have we had any others with similar amounts?
okay, so I think in terms of, no, I don't think we've had anything else at that scale, Councillor Hay. It's very early days at the moment, so I would say that is and actually compared with some other things that have been seen nationally, it is relatively not that large scale, but very important that we catch it at the right point. So more generally on the scaling up of contact tracing, we are working on this in our outbreak control plan. At the moment, as I say, there is capacity in the regional health protection team, of which this is their core job. It's their day job, even when we don't have COVID-19, to do the bulk of the contact tracing for local outbreaks. And obviously the 25,000 national staff have also been involved in some of that contact tracing around home contacts and so on. So there's plenty of capacity there, but we're planning for 3 different levels of need. So at the moment, we're kind of at level 1 when there's enough capacity to do this, but we will also send environmental health officers out to be closely involved with a local setting and ensure that the right advice is given. We then move up to another level where we would want to call on capacity from environmental health, from local public health teams, from other people who normally do contact tracing locally, like sexual health advisors. So there's a number of local staff who would do that, bringing those staff together and ensuring that they are mobilised into local contact tracing. And the third level would be quite a high level of outbreaks, and that requires undoubtedly additional staff. So in particular, we think training up environmental health assistants who are not qualified environmental health officers, but who can be given the right skills to do some of that work. So that's in our workforce plans that we are planning for different scenarios. The other issue that, unless Val or Raj can correct me, because I have been off the past couple of days, is not resolved, is whether we would be asked to do telephone contact tracing locally, or whether telephone contact tracing would continue to sit with the national and regional contact tracers, because you don't have to be within the local area to make a phone call, whereas you do have to be within the local area if you are going out to contact trace or provide infection control advice on the spot. So there is a question about whether the telephone tracing would transfer to us, which clearly would have additional workforce implications. And we're asking that question and working on that at the moment. But yes, we have plans for scaling up, which are not needed at the moment, but it's much better to plan for it. Have that in place.
If I could just come back on that, in this particular instance with Princess Factory, do we know how well the contact tracing has gone on in that particular case? Because we're hearing in the news in some instances where, particularly with telephone contact tracing, they're not able to reach people in all cases. And I'd just like some reassurance that they have contacted at least a fair amount of people who are known to have been in contact with these cases?
I'll hand you on to Val Thomas for that, Councillor Hay, because she's been involved much more closely while I've been off. She's been closely involved with the Prince's Factory. So I'll hand on to Val. I'm confident it's being well managed, but Val will have the detail. Okay, Val? Yes,
Sorry,
Val?
sorry about that. I'm back again now. Sorry. Yes, in terms of, there are two things. In terms of contacts in the workplace, the company immediately did take action to trace the contacts of the cases. And it was actually very much around a small office that was being used. That perhaps there wasn't quite as good adherence to social distancing as there should have been, but actions have been taken. And currently there are 16 people self-isolating because of the contact tracing on site. But outside of that, of course, there will be the families of the cases that have also been contacted and also being asked to self-isolate as well. So it seems, and I think Public Health England have now signed this off as being, actually they described it yesterday as an exemplar company in the terms of the way they did have prevention measures in place, but there was let's say a lapse amongst employees, and they've reinforced it. They've done a deep clean, shut the factory for 36 hours, went through all the contacts that the employers had during at that time. So it's been quite a robust response, and there was action on contact tracing in the factory, and the families were followed up through a test and trace system.
Thank you.
Thank you. Thank you. The last two speakers for Councillor Massey, please.
Yes, thank you. In regards to the numbers of COVID in Cambridgeshire, I think as far as we know, these were only for the Pillar 1 laboratory testings. Do we actually have the data for all testing? But also, I've heard, and it's come from a GP, that if you have symptoms and then you get a test after 4 days, then the test is not accurate any longer. So we've got cases of where I've got colleagues who have definitely got symptoms of COVID, and then indeed they're very poorly, but they've tested negative because they tested themselves. A, it was a self-test, so it's not an easy test to do yourself, but B, when the result came back negative, but yet the GP is still treating them as COVID positive. And I think we're missing these numbers really to be able to understand the level of COVID that is still circulating in the city and in the Shire itself. And in addition to that, the antibody tests, which I think that's the one that most people are looking at to see how much of the population have had COVID. I also know that's not quite accurate, because I know people who've been COVID positive and the antibody test has very low numbers of antibodies in it, and some other people who maybe didn't have symptoms had an antibody test and they've got high levels of antibodies. So it's kind of difficult to be able to pinpoint that. So the first question really is about what you think the actual, do we have the data for the actual assumed number of COVID that is still circulating within Cambridgeshire? And then number two, what are we doing to forward plan? Because when you talk about all the factories that are having issues at the moment, that's due to low temperatures, which would indicate that come winter, we might be in some problem if this is still circulating. So what are we doing to forward plan to make sure we don't have to help a COVID peak at the same time as a flu peak and a rotavirus peak and all the other winter bugs that fly around? Thank you.
Okay, so very good questions, Councillor Massey. So on the COVID testing, we are starting to get the data through now on the Pillar 2 tests, the national tests. Where you'll see those published at local authority level is the weekly Public Health England surveillance report, which is put out usually on a Friday, and that does have a national map. Otherwise, those results are not published because they're still quite developmental. And we know that throughout the outbreak, many people, as you say, with COVID-19 in the community have not been tested. So it can be quite hard to interpret trends in those tests because they have come in more recently through the national expansion of testing. Most of the tests are run in big national super labs, and eligibility for those tests has changed. So that is still developing in terms of understanding of the picture and the trends, but it is published in that weekly surveillance report, which I'm happy to provide or circulate. You talked about a GP saying that not everyone who had the disease, if their test came a bit too late, and certainly the tests are best in the first 3 days after symptoms, they might not always have a positive test. I think you can say more than that. There will be people in the community who have COVID-19 who either don't have symptoms and don't go for a test, or perhaps go too late. So the tests do not fully describe the levels in the community. And our best guide to that is the National Office of National Statistics survey, which tests a sample of the population on a regular basis to find out how many people test positive on any one day. And what they estimate at the moment is that nationally there's about 33,000 people with COVID-19 in the whole England population. That's about 1 in 1,700 people, which is a much lower level than at the peak. So that is what I would look at to estimate levels in the community, rather than counting numbers of positive tests, to be honest. And we don't have any evidence at the moment that Cambridgeshire would be different from that, because our numbers are low at the moment. I agree with you also about the low temperatures and the planning for winter, and certainly by getting our local outbreak control plans in place now and getting our systems built up, that does help us to prepare for what will be inevitably a more difficult time in winter, partly just because a lot more people will have symptoms of temperatures and coughs, and therefore more testing capacity will be needed to see what it is that they've got. And then we wait to see the impact of the low temperatures on COVID-19 itself. So I think that was a very good question. I think that nationally and locally, we're quite openly talking about that and working to prepare for it. And we're still at relatively early days with this virus in terms of our full understanding. We haven't seen it for a full year yet. So we will continue to learn about it as time goes on and into the winter.
Can't hear you, Peter.
Thank you. Linda Harford, you had your hand up.
Yes, and my questions have been answered actually, but as I've got the stage, can I just quickly say a big thank you to all the public health team. I know at one stage I was a particular nuisance about testing in care settings, and you know, I appreciate what everybody else has already said to thank the team. You have done a fantastic job, and I do want to say a special thank you for all the attention you paid to the endless questions and challenges that I was raising. So thank you very much for that. And finally, I do want to just endorse what was said earlier about homelessness, because it is incredibly important that we harness some of the good that's come out of getting people off the street. And I'm not quite sure how we're going to take that forward, how we're going to keep a lot of those people housed going forward, because as far as I can see, government funding is only for a limited number of houses to be built to house these people. Well, that all takes time, and the accommodation we need is now. So I think that, you know, the work with the districts needs to be as close as possible, because, you know, the very fact that some of these people have engaged, that they are seeing an opportunity to turn their lives around. Do we really want to throw them back out on the streets? So
No,
I just endorse what has been said. Thank you.
Yeah, we've already discussed that, and we are going to take that forward. Okay, I did close the list. Jeff, you're naughty. I'll allow the next two, as long as they're really quick, please. And then we're moving on, because we're running quite late, because this is important, that's why. Jeff.
Okay, just to concern consistency of operation across general practices. Granta, I think, which is my local practice, operating a very low number of actual physical appointments, doing most across the phone. Are we sort of confident that we're not building up problems for the future? For example, smear testing, you know, these things, we really perhaps should make the most of what seems to be a lull between a first wave and a possible second wave to kind of push those physical contact cases back to where they should have been. And I know there's some differences between the way local practices are actually handled.
Yeah, there are. My local practice isn't seeing anybody physically unless it's an emergency. So it's all down to the local practitioner, I would suggest. Liz, would you agree?
Yes, we haven't reviewed the various different ways of working across the general practices, but I would say that there has been some learning from this in terms of what can safely be done virtually. And there has been some, in a sense, some positives and learning out of that, but also concerns that some, as you say, some of the appointments that require physical interaction may not have been happening. And I would agree that it would be worth trying to catch up on some of those where there's a need. I wouldn't disagree with that at all.
Yeah, absolutely. Thank you very much.
Flu vaccination is something that we absolutely need to do for this winter. I would emphasise that. That's a physical intervention and absolutely needed.
Yeah, thank you. Councillor Jones, once again, very quickly, please.
Yes, I'm sorry, and I didn't intend to come back, but I was really kind of quite alarmed by a comment that Val made about the Prince's factory, which was that there had been measures in place, they had lapsed, and they had been restored. And it struck a chord with me because we're now opening large parts of the city, large parts of retail. There's all sorts of messages about go back and go out and all the rest of it. The 2 metre rule is being relaxed. You can have a 1+. Seems to me this is a moment of really high risk. And I did wonder whether as a health committee, we ought to be making this statement. I mean, you know, it's the flavour of the past in a way to say, oh, that's all gone. Let's all come back. Let's enjoy ourselves. But it's a moment of such high risk, much higher than we've had before, really. And I just thought as a health committee, we needed to kind of acknowledge that.
Oh, can I just respond to that? I think Peter's...
Val, do you want to respond to that?
Yes, yeah. Sorry, I did. Yes, I agree with the latter part of what you said.
Hang on.
What you said, Linda. In terms of lapse, I don't think there was a lapse. I was trying to avoid sort of the blame sort of thing of blaming individuals. But let's say there was a behavioural issue amongst a couple of individuals. It wasn't a lapse in their systems at the factory, which they'd established at the start of the pandemic. But I think the issue is that there are those, let's say, the messaging has to very much have, as you say, have to be reinforced over and over again. And this was an example where perhaps the messaging had been forgotten a little, but I was trying to avoid to put blame at certain individuals.
And if I could come in, Peter, just to say that if you look at any of the scientific advisors, the chief medical officers, and so on, they are all saying that this virus has not gone away. And that we are relaxing in order to stimulate the economy, get our children back into school and educated, do the things that we need to do as a society, but that at the same time the virus has not gone away and people need to be as careful as they can and to observe the social distancing, not just because there still is social distancing advice that's being given. And I agree, it's very important that we give the message that there are these further relaxations, but the risk is still there, and make it 2 meters when you can. Sometimes when you can't, it's 1 meter. That's what's coming in future. That's not where we are at the moment, but those messages about 2 meters where you can will continue to apply, and we need to continue to give them as a public health team, certainly.
Thank you. Thank you. Spooky that, Jeff. That was my GP on the phone. Arranging a meeting with him next week. There we go. Anyway, so that's fine. And the recommendation is we're asked to note the contents of the report, which we do. And thank you again, Liz, for all your work. And thank you especially for coming today. Right, so if we now go to item number 8, please, which is the COVID-19 impacts on Public Health Commission services. And Val is going to introduce this. Please, Val. Val, you're on mute. Val?
Yeah, I'll be with my screen collapsed with my paper up in front of me at that moment in time off the, because I had it off the main right. Just if you ask me questions, I want to be able to go to the particular paper. Right, I'm sorry about that.
It's okay.
Yeah.
Are you ready to?
Okay.
Yeah, let's go.
I'm here. Yes, I'm ready now. I'm sorry. Okay, I will. This paper describes the impacts on a lot of our Public Health Commission services. Obviously, Raj will talk about the Healthy Child Programme services in the next item on the agenda. The paper picks up on 3 main areas of where the impacts have been felt most of all, but the 2 main ones are our delayed procurements, and the second one I think has been on the delivery of services themselves, and the on the whole, the learning that it's given us in terms of the different ways in which we can deliver services. And also some of the negatives, and the work that we've been doing very much with the services is saying, okay, what have we learned? What do we want to keep? And what can we develop from the learning? And this is work that just started, I think, probably as soon as we could, once we got over the first kind of, we've got to do something and look at ways in which we can deliver services. And probably across all the services, they used significantly virtual approaches. And that ranges from sexual health services in terms of giving advice virtually, through to the lifestyle services where they're doing kind of group physical activity sessions online, and our drug and alcohol services as well have done a lot of remote consultations, and we've had a lot of positive feedback because what that has enabled as they've had more frequent support. And I think overall we've had very good positive feedback from the majority of our clients and patients. I think the issue for us is that virtual has been great, but there is something about which I'm hearing more about, the digital inequalities, that the people perhaps who are not accessing services because they don't have easy access to digital and virtual means, they are the people that we haven't been able to reach so easily, and we've had to go looking for them. And I think that's my concern in the longer term. I think the other sort of innovation that seemed very popular and which has been evaluated nationally in sexual health services, where you had an increase in online testing, application for testing online, and that's been expanded considerably. You know, it's where people, they apply online for a test, they are sent the appropriate swabs, and they send them back to the labs, and then they get the results, and that's been developed further, and now patients are being sent their treatment as well by mail. And I don't think it's just local to our services. It's been a kind of national trend in the delivery of some of these clinical services, but certainly we've had very positive feedback about that. Another aspect in terms of drug and alcohol services has been that, and I know, and I'm picking up on that because I have had questions about it. During at the start of the pandemic, the demand on our community pharmacies who provide supervised consumption, that is methadone, to people in treatment for drug abuse, just could not meet the demand of prescriptions, and they were very heavily oversubscribed. So to some degree, the services stepped in, and we're seeing people, particularly the higher risk individuals, but we also decreased the time interval, so going from daily pickups to weekly or 2 weekly pickups, depending on the risk of the particular client. We have not had any increase in drug-related deaths because of that, which we are very pleased about. But we are starting now to move back to having that more frequent contact with people. Since I've written this paper, it's like everything in this pandemic situation, things move very quickly. And I think going back to, I think there was a question about long-acting reversible contraception, which during the pandemic, the community services, the ICASH services, basically were offering services to the high-risk groups, and for more non-risk people, they were pausing it. That has now started to be reintroduced. And the first people that they are seeing are those who had already had appointments booked, or already sort of mid-treatment. So that's starting to go back to normal types of services, and obviously the services where you have to have face-to-face contact. In terms of the lifestyle services, they are now doing, for example, in weight management services, they are doing small groups of 5 physical activity, complying obviously with social distancing, because it's been rather a concern for us that all the support that we've given to people in weight management service has been distant. So that is now, at the moment, that's being risk assessed against the appropriate guidance. In drug and alcohol services, some of the clinic locations had been, particularly the outright outreach services, had been closed. Those are now in a process of being risk assessed to see when they can reopen. And in terms of general practice, I think Liz painted the picture, and it's very variable. We've certainly seen a decrease, because for obvious reasons, at our activity and practices. Perversely, in smoking, there have been a lot of referrals to the lifestyle services, which has been very good. We've never had so many referrals, in fact, so we are really pleased about that in Cambridgeshire. Health checks were paused nationally, but some practices, we are starting to get a trickling of data have recommenced providing health checks. And our integrated lifestyle service has offered to support them on that. And they are very much geared up to that. And those are the ongoing discussions at the moment. In terms of GP long-acting reversible contraception services, again, that's very slow and it varies considerably. And I think, as Councillor Hudson said, practices make their own decisions about their return to face-to-face services, but we are starting to see some activity coming through. So that's sort of very brief run through of the impact on service delivery models and some of the learning we've had from it. 2 of our, it has affected procurements. One, the sexual and reproductive health service, a collaborative model, which we were doing with the CCG and NHS England. We have postponed that procurement. Obviously the NHS was extremely busy and it would have been impossible, but more importantly, we tested the market and there was certainly no appetite. And it's very difficult to have any any client transfers without any type of face-to-face contact. There has been some delays, 2 delays in the implementation of services, lifestyle and the prevention of sexual health services, for the same reason, that it is very difficult to transfer staff and patients at this time, and services trying to make sure that services maintained in a very difficult time, and the demands it puts on staff, again, in terms of their own health. So, but we do have dates, and we are currently in mobilisation stage phases for both of these services.
Thank you, Val. I've got 3 hands up at the moment. Can I start with Susan? Susan, please.
Thank you. And thanks very much, Val. I have a general point, which is about the emphasis really in the paper on financial impacts and governance, though I feel the introduction that you've given is much more, it is much broader than that. And I was going to ask if in our recommendations, we could actually bring in the point about learning and development from learning, and anticipating impacts on people. So that section on recovery and new normal, I think, has some really valuable points which should be incorporated, could be incorporated into our recommendations at the top of the report, so that it reflects a much wider picture. Maybe we can come back to that if others are agreed. There are a couple of particular points in the report. I was glad to hear you talk about the state of the virtual world, and certainly in my division, lack of access to IT has been hugely illuminating in a community that actually the lack of access is far greater than we had thought. But there's also the question, especially in terms of children's well-being, as to the appropriateness, or the virtual experience can do so much, but there are things that it can't do, and there must be concerns there. Shall I just give you my other couple of points?
Please.
There's, I think it's paragraph 2.1, the impact on staff. It would be really good to understand more about the impact of the council's response on its staff in a wider sense, not just on the public health team and related services, but the broader impact. I mean, I know our local highways officer is on COVID response. And so to have a picture of this as it transitions going forward would be really helpful. And then finally, just there was a statement made in this paper and the next one, I believe, it simply says funding shortfall may be met by reserves or COVID-19 emergency funding. So I'm sure that's something we want to keep an eye on. So if I leave it at that, I haven't proposed a form of words for an additional recommendation, which I should have done. So maybe I should work on that while the others are having a go. But if that is something in principle that you would be agreed with, I'd like to propose that we try to work in some positive words there on learning. Thanks.
I would absolutely agree. I think, sorry, I don't know you're asking me, Councillor Hudson, but I would absolutely agree and to articulate it. But I think what I think is part of the recovery structure, which is taking place across the system, where you have sitting under the local resilience forum, where you have a number of recovery groups which are looking at the impacts and looking at going forward. And for me, what's interesting about that is the commonalities in each of the recovery areas, and what has come out, for example, around what is being termed digital inequalities. So I think it is a very good point, and to express it more strongly at the beginning of the paper would have been very good.
Emma.
Quickly, Susan, do you want to come back quickly?
Yes. Just one extra strand on the learning. We must not lose the opportunity of learning from all of the very local community COVID response groups, which have been doing some really innovative work and which are so well positioned to play a role in so many of the aspects of the council's work going forward, including test and trace, but also the many social inclusion programs that have just sprung up all over the place, and which personally I would hate to see disappear even after the crisis is over. So if we can do that with the directory that we've got. Thanks.
Thank you. Of course, that's a lot of local stuff. It's happening in my area. There's a massive teams of local volunteers, including myself, going round and make sure all our people who need help actually get help. Will that continue? I jolly well hope so. I don't think it will continue as much as big as it is now, but we've got a whole new sense of community spirit has built up the last few weeks, I've found personally in here. Councillor Netzinger, please.
Thank you. Thank you very much, Val, for an excellent report. I've got some comments to make on children's vaccinations, but I imagine that's in the next paper. So on this paper, I've got 2 points. The first is that you mentioned the impact of the fact that tier 4 inpatient opportunities have effectively closed for those needing detox for drug and alcohol abuse. Do you have any information about the impact of that? And do we know if there's been an increase in deaths from overdoses, or has it all been, I mean, the world is different or has been different outside. So it's possible that that hasn't been, and that would be very good news. But I'd just like to know whether we have data on the impact of that. And the second slightly wider point was on the sexual health team, who have obviously been making an enormous effort to try and do their work, but it's extremely difficult under these circumstances. There have been quite a lot of reports nationally about increases in the number of abortions and pregnancies. And I just wondered if that was something that we were picking up in the Cambridgeshire data. And with if there is an increase in the number of pregnancies, whether we have any idea about who those people are and whether there is an increase in pregnancy among teenagers or very young women or otherwise vulnerable women, because if that is the case, that will have potentially an impact on other services going forward.
Drugs, in terms of the drugs and alcohol services and the tier 4 for detox, people requiring that inpatient detox have received extra support from the services, and where possible, they've had a community detox with our existing services, because they are a particularly vulnerable group. And I think it's been quite interesting, actually, that because so much of the activity has moved to virtual, that the staff have been given extra support where needed, which again it has been a very positive in some ways. In terms of drug and alcohol related deaths, at present, we are below where we are normally in our numbers. So that, I think that was that. We have been, the member of my team who works on this is incredibly assiduous about it, and monitors it extremely carefully. In terms of the sexual health services, the data around sort of abortion and teenage pregnancy, there is a lag. So it's quite difficult to say at this moment in time. I haven't heard, you usually hear something along the line in Cambridge, certainly along, you heard anecdotally, and certainly amongst practitioners. I haven't heard anything as yet for Cambridgeshire, but it's something that we always listen out for very carefully, because I think there is that risk as we go along. Certainly in groups where we know who are particularly at risk of unplanned pregnancy. And we get that intelligence very much from the services as well. But it's something that does, it is a concern. I agree.
Thank you.
Thank you for that. Thank you, Val. Councillor Jones.
Thank you. Well, we've paid tribute this afternoon, quite rightly, to the public health team. But I would like us all to pay tribute also to some of the provider organisations, which we haven't actually mentioned, except in the fact that they extended services. And I mean, I have a small provider organisation, Specialist Sexual Health Service in my division, Diverse. And I know that the very short notice for an extension of service because of COVID caused a huge amount of disruption and a need for considerable flexibility among staff. And I'm sure that isn't the only small organisation that was a provider who had to make adaptations at the last moment and have contracts extended. And I would hope that those could be acknowledged too, because I think it is important going forward to make sure those relationships continue and are built on in a sensible way. And I would just make the contrast, because one of the interesting things I read in paragraph, that was paragraphs 2.3 to 2.7, by the way, but in paragraph 2.13, there's a comment about Healthy Fenland and the fact that the Healthy Fenland Fund was able to respond to demands for support and be able to provide more support in that area. And it did strike me that the advantage of having funded projects like that mean that they can then be used to support in these kind of emergency situations. It's something I think the Health Committee should take back and have a think about in the future.
Val, do you want to come back on that briefly, particularly about our providers?
Yeah, I would absolutely concur with Linda about our providers during this period. They have been, from the beginning, they responded very swiftly and taken measures that they had to take and looked at how they could maintain contact with their patients and clients and to give the support that's needed. And I think those who have to go through various contractual changes, whether it's contract extensions, delays in implementation, and all the insecurities that creates for staff, I think that deserves a lot of praise. And I think the important thing is that in the midst of all of that, they kept providing the services, because at the end of the day, it's the people that really matter at the end of the services. I think staff matter immensely, but I think the credit to them for maintaining those services. And I think I would agree with Councillor Jones that that's a good point.
Thank you, Val. And
just a thing about the when Councillor Hudson, when you mentioned about you thought that the community spirit had developed and grown, and I think that's been fed back to me very strongly in Fenland, and the number of groups that the Fenland Fund are very much aware of that have started independently and now want to continue. They started to support COVID, but now want to continue as groups.
That's really good news. Thank you. And the last speaker, please, Councillor Goldstack.
Yeah, I'll keep it quick because I'm not 100% sure where this fits, but when I was reading the report on the drug and alcohol treatment services, it highlighted something that's happened locally to me, as Peter's mentioned, and I saw many people were nodding about being involved in the local volunteer world. What I've found is there's been quite a common joke during the last 4 months of nobody knows what day of the week it is. Is it yesterday, today, or tomorrow, the only three that matter? What I would say is some of our services stayed on a Monday to Friday basis, and that has caused some real angst and issues for many people in the community that have been suffering, particularly those at the end of, now maybe in the mental health world that have come from the drug and alcohol world. And I think that's something, God forbid we get into this position ever again, but certainly for a second spike or in the future, I think maybe we can look at a little bit more fluidity in that area to be able to make that accessible services more available, basically. I know some people on a Friday evening trying to get through to mental health workers have had real difficulties and other things that, we've picked up in a local environment. So if I could just ask you to, I'm not expecting answers on that, but I'm just asking that for something for the future and something to consider.
Thank you. Yeah, we will consider that. Val or Liz, the 111 option 2 has still been running, hasn't it? For mental health?
I think so. I believe so, yes.
Yeah,
Oh,
so if there was a...
Yeah.
Yeah.
No,
so
I think no change.
If there was a mental health issue, dial 111, take option 2 to get through to a mental health expert straight away. But I mean, that's something that we could look at, Mark, particularly going to the future.
There has also been an expansion in voluntary sector telephone counselling, expansion of Lifeline, which we've been very involved in commissioning. So the services are out there, and there should be information about them on the website.
That's right. That's our age-old problem, isn't it? Making sure they know about the services they can get. And that's always been a difficulty, is something we have to work harder on, I think, as a committee and as a directorate. But okay, thanks very much. Okay, I'm going to come back now to Susan briefly, because you wanted to, are you there? Talk to us, Susan. There you are.
Got it. I said I would propose some words if nobody else did.
Yeah, go on.
We could have a fourth recommendation, very simply harnessing learning from the experience of COVID response, including at the most local level.
Yes. Rob, did you get that? Rob?
I was trying to put it on chat so you could see it, but I couldn't find that function.
No, it's been taken away. Rob, are you there? Sorry, no. Rob, did you get those extra words from Councillor van der Ven?
harnessing learning from
harnessing learning from the experience of COVID response, including at the most local level.
Including, yeah, I think you said particularly at the local level, but that's fine. Including at the local level, yeah, at the local level, yeah, got that.
At the most local level.
At the most local level.
Okay, if anybody objects to that, could you use the raise hand function, please, and we'll talk about it. But if you're all happy with that, then we'll include that. And there's no raised hands, so we'll include that. So we're asked to support the changes to the delivery of Commissioner of Public Health Services and the implications for ongoing service delivery. We're asked to support the financial implications arising from the revised procurement and new service implementation schedule. And we're asked to support the payments to providers aligned with Cabinet Office Policy Procurement Note 02-20. And we're asked to support the extra words that Linda's just proposed and Rob will write down. If anybody objects to any one of those recommendations, please use the raised hand. If not, I'll take them all en bloc and we'll move on. Okay, there's no raised hands. I'll just check in twice, thank you. Okay, so we'll take that as read. Thank you for that, Susan, and we'll move on. Thank you. Thank you, Val. So, item 9, please, the Healthy Child Programme's response to COVID-19. And Raj, this is yours, please.
Thank you, Chair. And I'll summarize where we are at with the Healthy Child Programme and the Best Start in Life Programme. And to echo Linda's point about the great work that our providers are doing, I think we've got a lot of emails as well, especially one from our safeguarding nurse at the CCG, who's always very critical, who's always looking at us very carefully. And she sent an email saying how proud she was about how well the Healthy Child Programme had done compared to other areas. So especially in Cambridgeshire and Peterborough, the experience has been great, she said. So the Healthy Child Programme is health visiting, school nursing, and family nurse partnership. We have a Section 75 agreement with Cambridgeshire Community Services NHS Trust and CPFT to deliver that. And on 19th of March, when the COVID prioritization, when NHS England and NHS Improvement set out a paper saying how to prioritize community health services, there were 4 main principles about supporting home discharge, mainly to protect the NHS, use digital technology as a default, support high-risk individuals. Those are the clinically vulnerable people who were asked to shield, and also provide mutual aid. So to support the rest of the NHS response. And I think fair to say our providers were not asked to provide mutual aid to the NHS. So we did retain all our health visitors and school nurses doing the job that they're employed to do. So we did have initial discussions about whether they would support maternity and some of the hospital thing, but fortunately it didn't come to that. And they also said that there were certain elements of the community Healthy Child Programme that were essential, and that was the antenatal and new birth visits and maintaining a single point of access, which I will go on to describe what we did, safeguarding work, and family nurse partnership. And it's good that we've kept that going because it's recognized as an important part of the Healthy Child Programme. So we've had weekly calls to actually, as the pandemic was evolving, we've had to look at different staffing levels and different levels of where we are going to stop doing stuff, where we're going to focus our energy. So we've been having weekly calls to discuss that, and very good relationship with our providers. We've had weekly reporting from them about all the mandated contacts and how many are being done face-to-face, telephone, video, and in addition to the monthly performance meetings that have carried on. So in terms of the health visiting mandated contacts, they've been initially provided by telephone or video conferencing, which is what was recommended anyway. And then after, if a face-to-face contact was considered essential, there was a risk assessment undertaken to look at whether it was, if someone was showing symptoms or if social distancing could not be managed, then staff were using PPE in line with NHS Trust infection control protocols, and if it was considered that a home or clinic visit was essential. So from the 18th of May, I'm happy to say that the new birth visits now are being done face-to-face, and the baby is being weighed and other clinical assessments are being undertaken. So that's a change more recently. I also already mentioned about redeployment, and because we've had less face-to-face contact, we've been able to provide more phone contacts between 4 weeks and 4 months for some families where the health visitors felt there was a need for extra support. So this was in addition to the mandated contacts. The other good news for Health Committee, I know you were very worried about the antenatal notifications and how the cooperation with maternity services was going, and we always had that as an issue for a long time. And because of COVID, the one thing that happened was maternity colleagues from all 4 catchment hospitals have set up how we would deliver postnatal support and sharing scan data. And I think we've submitted a case study to a Public Health England report on this issue about how we were doing that, and hopefully if it's included, we'll share that report. Vision screening has been suspended until the new academic year, but as soon as we are informed by nationally that it's safe to do it, we'll restart it. In terms of the rest of the school nursing service, call us, text us, chat health has been going on. And in terms of that has been expanded to a single point of access, and it includes the emotional health and well-being practitioners who support the school nursing team as well. And also it's a single point of access to all the specialist services, including the community specialist services, physio, occupational therapy, specialist nursing, and pediatrics. There is also an online platform for self-help, more and more materials being put on there, and I've put the link into the program, into the paper. So again, the Universal Plus and Partnership Plus contacts happen in liaison with the social workers, and the Healthy Child program continue to fulfill their safeguarding duties. And as I said earlier, they have the school nurses have been joined by the emotional health and well-being team. FNP again, it looks like this cohort of young teenage mothers have been enjoying I mean, they've accepted the video conferencing, and it seems like it's going well for them, and something that we may think we will continue doing, especially in that cohort. So moving on to Best Start in Life, as we all know, it's a strategy or a play or a vision to bring the Healthy Child program to work together with our colleagues in maternity, children's centers, early years settings, and the NHS. So we are giving the same consistent messages across all the practitioners working together collaboratively. And we've started, although we had to suspend that program, people have been meeting, the implementation group have been meeting regularly, and they've just about started the place-based protocols, operating the place-based protocols, and hopefully we'll come with a separate report on that program of work as well at some point. So in terms of, I think the Best Start in Life having that strong partnership was really helpful when COVID started, because as I said, the Healthy Child program buildings could be used to offer maternity visits when the GPs closed their premises to only clinically unwell patients. We could use the children's centers for them to do their clinics as well. So the maternity clinics, maternity colleagues really valued that joint up working. And then we've also had regular meetings with the CCG and primary care to confirm that all the essential health checks, including the maternal mood reviews, are being undertaken. So the GPs had to move their newborn infant physical exam from 3 to 8 weeks to the time when they came in for their immunizations. But we were monitoring all of that to make sure it was all happening. And then we've tried to now we're now working on recovery planning again with the NHS. And I think the CCG or STP have set up a separate maternity and children's recovery group, which is a good thing. So we are making sure that this program of work will carry on. And we're very much involved in the recovery planning. On our side, we have done lessons learned. In addition to what staff have been telling us, we've tried to look at what the staff experience has been. We've also been collecting information on service user experience. And as Susan talked about vulnerable groups, we are trying to understand the different impact this period has had upon various groups, and especially understanding what risks and what mitigating actions we need to take. And yes, especially among children, we know that domestic abuse call lines have gone up. So we're worried about that and trying to explore how we can work with the earlier settings and school and education as well. And yes, I'm happy to take questions.
Thank you, Raj. That's a really, really good paper. Thanks very much for expressing it so well, as always. A couple of speakers, please. Councillor Netziger.
Sorry, thank you. Just picking up on the points that you were making about vulnerable groups. One of the groups that I'm interested in are children who have missed vaccinations. Presumably there is quite a large group of children who should have been due to receive vaccinations over the last 3 months. Some of them in school and some of them just in the normal routine health visitor. I know that some of those vaccination programs have been continuing, but I suspect that there's a very large number of children who won't have come in to have their vaccinations as a result. Can you tell me a little bit about what your plans are for making sure that they do keep up to date? Because as was discussed earlier, the last thing we want is a measles or mumps outbreak on the top of COVID.
Exactly. And vaccinations are a big priority for us. I forgot to mention that, but it is a big priority for us. So we are trying to get from NHS England the report, and we know that nationally, and we've got our data about the local vaccination. We are pulling together a group with including NHS England and our Healthy Child Programme providers to promote vaccinations. We're already doing a lot, but we need to do more to make sure that everybody who has to have it and was scared to go into their GP practice to have it gets it. So that's very much on our radar. It's very much on a priority for Best Start in Life. And we are trying to promote it through all earlier settings, children's centers, Healthy Child Programme, everywhere. In terms of the school immunizations, again, there is a catch-up program all planned and penciled in about how we do the catch-up school immunizations as well. So the vaccination catch-up of school IMS and of the baby immunizations is a priority for us as well.
Thank you. I have a particular concern that that while a number of people will take their children in and respond to those catch-up immunization programs, the ones who don't will be particular groups who it's hard to get to, and that we may find that we have higher numbers of unimmunized children in some populations around the county. Will we be mapping that at some point?
So we will look at the data from NHS England. So I think the cover data is collated there, and we are going to talk to our NHS England colleagues to see about how other areas are also trying to get to the hard to reach groups and what they've done in other areas.
Okay, thank you.
Thank you.
And
Councillor Harford.
And we will be working closely with our health protection leads in the council as well on that.
Thank you, Raj. Thank you.
From them.
Yeah, thank you. Councillor Harford, please.
Thank you. Councillor Netzinger has just asked what I wanted to ask. Thank you very much. I just wanted to ask what, in addition to that, what thinking outside the box there is about the availability of vaccinations, because when we talk about hard to reach people, I think that that covers a multitude of sins actually, and that some of the hard to reach people are actually in the not necessarily in the areas of deprivation or anything, but they're people who have their minds on their careers and other things, if I may be so bold as to say. And I just wonder if we are doing any work to think about how we could increase the opportunity for vaccination outside of normal hours or whatever, to at least get to some of them. Thank you.
Thanks, and that's a really good point. So the vaccines, the baby vaccines are delivered by the GP practices. So apart from promoting it, there's very little that we can do in terms of encouraging people to go. We don't actually deliver the vaccines. It's the GP practices. And I know it's very much on their radar as well about inviting people back for the for getting immunized. And there's lots of myths and about vaccinations as well, which we try through social media and all sorts of venues to try and dispel a lot of the myths. Again, as I said, we can only try and encourage and provide information and do everything to promote it. I can talk to our primary care colleagues about whether they set up. I'm not, you also mentioned about vaccination availability. I think shortage of vaccinations, we haven't heard about any shortages of any vaccinations, but about whether GPs would be willing to, and maybe they are, I've not explored that in great detail, but we are talking to our CCG colleagues, and I know it's very much on the CCG's radar as well, and primary care deliver the vaccine. So unless they agree to expand their hours to do it, I think there's very little we can do about that.
Thank you, Raj. Yeah, Linda, are you happy with that? Want to go back quickly?
I just wanted to say that perhaps that's something we can take up at our liaison meeting with the CCG, because now that we've got these new groups forming, sorry, I've forgotten what the jargon is right at this moment, but it does mean that GPs have got the opportunity to offer additional services. And I know that some of the GPs I've spoken to have talked about much more group sort of work in different locations and things. And so I wonder if we could talk to the CCG about how they might incorporate some of that sort of advice into their monitoring of GP contracts.
Yeah, that'll be a great help to us if you could raise it there as well. That would be good.
Thank you.
Thank you. Yeah, that'll be good.
Thank you, Linda. Councillor Jones, please.
Thank you. Yes, mine was also on paragraph 4.2, but it struck me that paragraph 4.2 was quite a lot wider than just an issue about missed vaccinations. There's also a sort of issue about social isolation effects in children shielding. There's an issue about mental health. There's an issue about possible effects of domestic abuse, all of which have health impacts. And the Best Start in Life, the Healthy Child Programme, the Best Start in Life, is about the all-round physical and mental health of the child. And it did seem to me that that paragraph, probably because of the stage you're at, and I think Linda Harford is probing this too, it sort of hasn't kind of quite got to its conclusions yet about what the real impact of all this is. And therefore, what you're finding a way towards is a much more comprehensive mitigation strategy. And I think the suggestion she makes about the use of GPs is a really important one. But I would like to see, sort of, for a future committee, a more worked up strategy about how that mitigation could actually be carried through. Because I do worry that we are, you know, and it's back to the issue I raised right at the start about the impact of COVID on existing health inequalities. And I do worry about whether that is not, you know, intensified, perhaps even in children.
Yes, and we will get an update on where we are with that as a separate issue. And I think that's exactly the reason why the Children's Commissioner and the Royal College of Pediatrics have been lobbying to get children back into schools, and we trying to put in the support in schools as well, mental health support teams in schools. In terms of the domestic violence as well, I'm working with my social care colleagues, and they are trying to do more visits and trying to identify children earlier. The health visitors, of course, are doing that as well and raising concerns earlier, and if necessary, trying to get in there with a social worker or family worker. In terms of sorry, I forgot what I was going to say. I hadn't written it down. But yeah, I think, and also the shielded group, the good news is that the Royal College of Pediatrics have said they could reduce the number of children who need to be shielded because children aren't so severely affected by COVID. So there'll hopefully be a new list of children, and already the community pediatricians are looking at they've changed, the RCPCH have changed their criteria on who should be on the shielded list. So hopefully we'll get fewer children on the shielded list as well.
Thank you.
Can I just come back on that?
Quickly, Linda, please.
Although children are at lower risk, children can also be carriers and be at risk, and can take those back to people who are shielding. So, I mean, I'm slightly nervous about the comment you made right at the end there.
Yes, but I think these are the children who have been shielding, who not their family members shielding. They have been shielding for their own health reasons, but it has been quite a lot of children who were on the initial list. And the new guidance seems to say if they are only being treated in primary care, they don't have severe immunodeficiency or whatever, they themselves are not at a great risk. I'm not at all talking about the adults who are shielding. They are different, but the children who are shielding, they think they can reduce the numbers.
Thank you. Thanks for the clarification.
Thank you. Thank you, Raj. Councillor Massey.
Hi, yes, I think I'm just going to add more problems and questions rather than ask a question. And I think this is possibly more focused on the CCG than it is this committee. However, when we're talking about health vulnerable children, and the fact that we're trying to reintegrate them back into whatever normal life is right now. And then we're also thinking of trying to future-proof for the next coming waves, etc. It does strike me to ask the questions as to why we are not rolling out on a wider scale vaccinations like the RSV vaccination, which is currently only given to children up until the age of 2 if they're most vulnerable. Because of cost, I understand it, as I befriended a lady who actually created the RSV vaccine, Synergist, in hospital. So I know that it can be used not just for older children, but also for vulnerable adults. And that seems to me that would actually help somewhat the winter pressures, wouldn't it? But also rotavirus vaccine. There's a rotavirus vaccine. I don't know if that's routinely given anymore. It's been some time since I had a small baby to vaccinate. But we do have vaccines out there for our seasonal winter viruses. And it does beg the question as to why we're not doing it on a broader scale so that we can avoid winter pressures in the NHS.
Thanks a lot. And that's a really good point. The one thing about vaccinations, I would say, is that it's not a local decision. There is a joint committee of JCVI who actually decide what the vaccination program should be. and they look at the totality of the evidence. And there are countries which give totally different vaccination schedule, but we have to follow what the national JCVI program says. So I don't know the exact details about why they have not included rotavirus and RSV virus vaccines, but
Raj, if I could just come in there, please, because that's not a question we can answer. It's not in our remit. We don't roll out vaccinations, because if we did, it might be a bit more efficient. But that's not a question we can answer. Perhaps it's a question you might find out and come back to us at a later date, perhaps. Just out of interest for us.
Yeah.
Okay.
And out of interest, we're hoping that if all the social distancing and everything is still going on in winter, we may have fewer winter admissions and RSV and flu and all the rest of it as well.
Yeah, good. Thanks very much. Okay, can we go to the recommendation, please? And excuse me, we're asked to note and comment on the progress made to date in responding to the impact of the ongoing virus pandemic. We have commented, of course, and we have noted, and your comments, as always, have been smack on the ball and really good. So thank you very much. Thank you, Raj. That was really good. Thank you. So if we move on now, please, to item number 10, and it's the old annual issue of the National Health Service quality accounts, and we're to establish a process for responding to the 2019-20 results. Bit like Groundhog Day, this, isn't it, Kate? It's all yours. Thank you.
It is indeed. Would you like me to just provide some councillors with some background to the paper for those that perhaps haven't been on the committee before?
As quick as you can, please, very briefly.
I will do. So our provider trusts, which is basically our Addenbrooke's Hospital Trust, CPFT, and Cambridge Community Services, etc., are required to consult with the Health Committee and share their draft quality accounts, and that is a statutory requirement for them. The Health Committee doesn't have a statutory requirement to respond, but can respond to quality accounts that it receives. Normally, we're in a situation around about April, May time, where we're really pushed with very, very tight deadlines to respond to the quality accounts that we receive. And so in the past, we've set up these task and finish groups. Due to COVID-19, each of the trusts have been given an extended kind of remit in terms to actually complete their draft quality accounts. So they're recommending that they should have drafts with their stakeholders, which includes the Health Committee in your scrutiny role. They're recommending that you should receive those by the 15th of October, or at least be notified that you are, and then the final versions for publishing on the 15th of December. We have had approach from a couple of the provider trusts, one literally a few minutes before the committee started, and that was North West Anglia, that are proposing a 2-week turnaround, and they will provide the draft in July with a 2-week turnaround. So this paper is really to look at the proposal for you in terms of actually setting up a member-led task and finish group to establish a process to review the quality accounts and then complete the draft statement, which is published on your behalf with the quality accounts, and they will publish other stakeholders' comments as well. If possible, we're proposing this time round that we could bring back some of the statements for final submission for you as a committee to receive and comment on before we actually submit them. But just looking at the timescales that North West Anglia have given us, if they're all going to do a 2-week turnaround, that will be very difficult. So we probably do need to have the setup that's proposed in the recommendations, that a task and finish group reviews it, and there's a delegation to myself to respond on your behalf, and then you can all receive the final statements. So is that speedier enough for you, Councillor Hudson?
Yeah, thank you. Yeah, here we are again.
Yeah.
So really what we need to do, we need to decide, are we going to respond, which I'm sure we are, and then we need to find volunteers for the task and finish group. I know we have our resident expert, which I thank profusely for last year's work, but any help we can get from the committee obviously is required. Does anybody want to raise their hand and have a chat? There we go. And it's the resident expert herself, Linda.
You're too kind.
I know.
Chair. Well, I just wanted, in case I didn't know what people were thinking, oh my God, more work, possibly, things like that. But I did want to say that we have tried to lash the trust into shape now and tried to get ourselves organised so that the dialogue is actually kind of quite a useful one. And what I just wanted to say was, please don't, because the deadlines are tight, don't let it lapse this year, because I think it's really quite important. I think they do value what we say a bit more than they perhaps have done in the past, rightly or wrongly. I'm very happy to be part of the Task and Finish group to take the work on.
Thank you, Linda. That's really appreciated. Susan, do you want to speak?
I will bravely volunteer.
Oh, I've got a little list. Anne.
I will help on a Task and Finish.
Thank you. Linda, you're waving. Linda Harford, Linda with a Y. Were you waving at me? Are you volunteering?
Muted.
Yes, thank you, I am.
Bless you. Thank you. How many do we need, Kate? We have 4 now.
That's probably just an.
I think so as
waving
well.
Or.
Are you? Where are you?
Councillor Taverner's waving.
Councillor Taver, I can't see you.
Yeah, I don't.
There you are, Jill. Sorry.
I don't seem to have that hand thing on my taskbar. Yes, if possible, I'd like to be considered as well to be on there.
Consider it considered.
Okay.
Okay, so that's 1, 2, 3, 1, 2, 3, 4. That's 5 now, Kate. That's brilliant. Thank you very much indeed.
That's very good. Thank you.
So we'll go straight to the recommendations, and you've seen the recommendations. We appoint representatives to the Task and Finish group, receive a comment on the statement from the Task and Finish group, and if response allow, we'll have a full committee input. The members are asked to delegate approval if time allows, or we'll delegate it to Kate, basically. That's what they're saying. Are you all in agreement? If not, can you show your blue hand, please? I think we have it. I think we have it. Yeah. Thank you very much indeed. There you go, Kate. That was easier than last time.
Thank you.
Brilliant. Thank you, everybody, because it's really important. And they do appreciate now, after a couple of years of hard work, mainly by Councillor Jones, that they do appreciate our comments. So we go to item 11, I believe now, please, which is the Health Committee agenda plan, and also to consider the appointments to outside bodies, groups and panels. So our Democratic Service Officer, Rob. Rob, are you awake?
Yes, I am. Yeah, sorry.
Good. Thank you. It's all yours, please.
Yeah, so obviously Appendix 1 is the Health Committee agenda plan, which the committee reviews at its every meeting, and the most up-to-date agenda plan is attached to Appendix 1. In terms of the Council's constitution, the Health Committee is authorised to nominate representatives to outside bodies and advisory groups, and they're included under Appendix 2 and Appendix 3. In relation to Appendix 3, where the committee is asked to review the appointments, in relation to Cambridge University Hospitals NHS Foundation Trust, Councillor Governors, which is currently Councillor Howell, and also the next one, Cambridge and Peterborough NHS Foundation Trust, currently Councillor Graham Wilson. Both of them have indicated that they would be happy to continue to serve on these outside bodies if the committee is minded to reappoint them. And obviously Appendix 3 of the report has the internal advisory groups and appointments, the current ones as shown. And again, they're indicated, so the committee is invited to review the current appointments to the listed bodies.
Thank you, Rob. If you want to talk, could you raise your hand, please? I think perhaps we we need to, I mean, not now, we don't have to talk about it now, but I'd like to have some sort of reporting mechanism, especially if the people who aren't on the committee on a regular basis, that they can report back to the committee the business that's been going on their board or panel they're in. But we can sort that out at a later date. Kate, do you want to come in now?
Yeah,
Kate, you've got a hand up.
Yes, thank you. Yeah, my hand up was due to the agenda plan. So I didn't know if you wanted to move on to that yet, or are you happy for me to just quickly update you on the agenda plan? Yeah, so just to confirm, in the next meeting, which is the 9th of July, we have got confirmation that Jan Thomas is available. So the accountable officer for the CCG is available and will be attending the committee on the 9th of July. And I just wanted to let members know that we have restarted all the liaison meetings, which are our informal meetings with our provider trusts. So as of July, we will be meeting Addenbrooke's, CPFT and North West Anglia.
Didn't we mention we'd like to include Papworth, Royal Papworth? As it
Yeah,
is
we have. We've struggled to engage with Papworth because prior to COVID-19. So a couple of emails and we've also had an introductory email sent by Addenbrooke's to Addenbrooke to Papworth. But I would like to probably explore the Papworth liaison meeting, perhaps when we're a little less fraught by technology and having to do it this way, because it would be the first meeting that you've had. So I haven't chased Papworth, to be fair, because we've never had a liaison meeting with them.
Okay.
But those that we've approached again have all agreed and are happy to.
Thank you, Kate. That's fine. Mark, Councillor Howell.
Thank you, Chairman. Chairman, you might recall that I primarily went on to the Addenbrooke's Governor Board to make sure that they got their act together with regards to the DTOC. And I have been doing that. And I must admit, I've been reporting primarily that particular issue to the Adults Committee, which I was at that time Vice Chairman of. The only other report I give is, of course, to Annual Council, which is what we all do for all our reports, or we should do anyway. But if that's what you would like, I'm quite happy to do that. Either put a report in every whatever type of period, just to keep you updated what's going on.
I don't want to make too much work, Mark. The DTOC is mainly an adult committee issue, of course, of adult social care, but we also speak about it in health a lot, particularly the difference between the adult social care aspect of delayed transfers of care and the NHS. So we can scrutinise the NHS part of the delayed transfer of care. So if and when you brief adults, perhaps you could just drop a briefing note into us and we'll distribute it around the committee.
I'd be delighted to, Chairman.
No, thank you very much indeed. Thank you. Linda, with a Y. Linda, you're on mute, lovely.
Unmute. Okay, sorry about that. I wanted to ask why we never meet with CCS.
Good question, Kate.
Sorry, just trying to unmute.
It's okay.
I've never been instructed to set one up for CCS, and I'm happy to approach them if that's what you wish. But we've never discussed it in the past. So yeah, it's a good point. If members wish to explore that.
I do think that going forward, Chairman, it would be a really good idea for us to try and meet with them, because, you know, when we're thinking about trying to cap some of the good stuff that's gone on in the communities and the way that people have adapted, you know, some of our providers who, or not necessarily providers, but some of the third sector have really come to the fore, and we need to capture some of that good work. I think it would be useful. So thank you for that, Kate. I didn't mean to challenge you. You should have known that we wanted a meeting. The other thing I wanted to ask about is on the agenda, and that is that we have up until, I I think it's August. We include, no, we don't in August. We have got an item on there about COVID-19. Oh yes, we've got it on for July and we've got it on for August and September. And then the COVID issues report disappears off the agenda. And I just wondered if we need something on at some sort of regular interval that examines COVID readiness in case there is a second wave.
Yeah, I'm happy with that. Absolutely. Yeah, that's no problem. We'll make sure that happens.
Thank you.
Thank you. Susan?
Thanks. Just going back to Mark and Adam Brooks, I think we should make maximum use of your role, Mark, and maybe because it's a good opportunity. And I mean, one thought would be that we have our liaison group that meets quarterly, and perhaps if we could just touch base and discuss the changing picture and what we feel we need to make sure we're learning. And I'd be really delighted to have a regular report from you. But let's talk and coordinate between all of those who are on the relevant groups and have that interest.
Okay.
Chairman, through you, Chairman, I'm quite happy to do that. That's no problems, and we can discuss that out of this committee. No problems at all.
Thank you, Mark. That's very good of you. Linda, with an eye.
Thank you. I just wanted to pick up Linda Harford's point, which I think is a really important one, because one of the things I was going to flag for future agenda, we've already had a comment from Raj about bringing back a mitigation strategy in relation to those areas of vulnerability for child health. And we've also had a comment about future relationships with organisations that have helped us out over COVID. And we've also had messages about needing to learn the lessons from COVID and think about health inequalities in relation to COVID. So there are a number of things going forward, which, I mean, I think it's a matter for the public health team to decide what the timeframes are, because there's so much else going on. But I certainly think that whether it's a member seminar or whether it's a committee, I'm not quite sure, but there's something where we need to kind of have a lot of this data, have a lot of this evidence available to have a look at and think about the implications of it going forward.
Yes, Linda, we'll discuss that with Kate and Liz and get some timelines on that. Liz, you happy with that, yeah?
Yes,
Another head will do.
it needs a bit of thought, but very happy to work going forward.
Yeah, lovely. Thank you. Okay, so if we go to the recommendations now, please. We've been asked to review the agenda plan at Appendix 1, agree the appointments to outside bodies in Appendix 2, and agree the appointments to internal advisory groups and panels in Appendix 3. I should take all recommendations in a block. If anybody has an issue or does not agree with them, could you please use your raised hand thingy? So I'll take it we all absolutely agree. So that's a unanimous decision. As always, bless you. Thank you very much indeed. And I'd just like to thank everybody for attending today, especially Rob, our new man, and Rishenda, of course, who's kept it all going, tickety-boo as the host, and for Liz to take the day off her holiday. And I look forward to seeing you all soon, I hope. Thank you.